I'll introduce Bill very quickly, where without any disrespect, we're introducing everybody merely with their titles here and not a long bio. Bill is the Director of Health Policy at the Empire Center. Many of you know Bill from his many years as a columnist and reporter with the Daily News before he joined us several years ago, and he's quickly become recognized as a leading authority and analyst on these issues. So without any further ado, starting with Bill in his edge of the stage position, I'll introduce Bill Hammond. Take it away, Bill.
So you can't imagine how sorry I was not to have been here this morning. When I got here, I figured out what had happened. There were so many people trying to get to this event that they were plugging the roads all the way from here to Saratoga. So I'm going to give an abbreviated version of what I was going to say earlier, and it was meant to be kind of an introduction to that debate. But some of what came up in the debate is addressed in my presentation, and in particular the tax impact. There was a question about how can you move ahead with a bill like this without knowing what the tax impact is. I used the RAND study as the basis for some analysis of how the taxes would work. The RAND study, I guess a disclaimer, it's only one scenario. They came up with one estimate of what it would cost and one set of taxes that would finance it. It fits the requirements of the law, but it's not the only way you could do it. But I think it's revealing about some of the implications of single payer. So in any scenario, even the best case scenario, the New York Health Act would require more than doubling all state taxes. It would also mean pushing our top marginal rates to really unprecedented heights. It would put us in an outlier position compared to every other state. We wouldn't just be the highest state, we would be the highest by a factor of 2. And as a consequence, that would put our economy and the tax base at risk, because I guess you can imagine some employers saying, hey, we want to move to a place where we don't have to pay for health care. But there's going to be other people, other wealthy people who are thinking about where to live and where to invest, and they're going to look at those marginal tax rates and they're going to think twice. Another thing that comes up is that when you switch from a premium-based system to a tax-based system, it changes what people have to pay. Some people probably would save money paying this new tax instead of the premiums, but other people would pay more, and it's not necessarily in the pattern that people have been assuming. I'm going to go back a second. The claim has been made very often on the assembly floor and around the state that if this bill passes, 98% of New Yorkers would save money compared to what they pay now. And that sounds really good, and I think that was one of the reasons why it's gotten so much support, especially in the Assembly, and it has a lot of support in the Senate as well, is this idea that it's kind of a free lunch, right? You can have single payer, you can cover everybody for everything, no copays, and 98% of people save money. And that was a number that was in the original analysis by a guy named Gerald Friedman, who is a fan of single payer, and it was kind of a best case scenario. When the RAND report came out this summer, it had a much higher cost estimate. And so you started to hear supporters, instead of saying 98% of people would save money, they kind of backed off and said 90% of people would save money. In fact, the RAND report addressed this question, and that's not what they said. They didn't say 90%. They said that 31% of New Yorkers would pay more than they do now, almost a third, and that about half of those people would not be the wealthy. It would be middle income and low income New Yorkers who would face higher costs under their projection of the New York Health Act. it's not just the people who buy Birkin bags, in other words. It's the working poor and the middle class. So why would it be? This is how the Rand report depicted that picture. Those bars are arranged by income. So on the left, it's the poorest segment of the population. On the right, it's the wealthiest segment of the population. The red is the percentage of that group that pays more, and the blue is the percentage that pays less. And you can see there's an awful lot of red on the right-hand side because that's where the wealthiest groups are. That's about $250,000 a year and up, those two bars for a family. So yeah, those people are all going to pay more, in some cases a lot more. But if you look over on the left, those are the poorest people in the state. They're below $50,000 for a family, and the farthest bar is below about $38,000 for a family. So why would those people pay more under single payer? Well, the answer is that right now they're getting either free or nearly free care through Medicaid or the Essential Plan. Those two bars are specifically designed to represent the people who qualify for Medicaid and for the Essential Plan. And so if you have free coverage and then you get a job, and a lot of people have a job in those categories, and you're paying the payroll tax, your costs are going to very quickly exceed the $0 that you were paying before, or maybe the $20 a month you were paying before. And that's going to push you into the red. So I'm not necessarily saying that that's necessarily the wrong policy to ask people to contribute a little bit for their own insurance, but it belies the idea that this is a free lunch for everybody except the very rich. You'll notice in the middle income, it's mostly blue, but there's still a segment of the middle income who are paying more. And I made an attempt I'm not going to do that chart, that's too complicated. But what I did was I tried to figure out at what point for different groups of people would the taxes be more than what they're currently paying for insurance. And so if let's say you're a single person and you have individual coverage through your employer, on average, you're paying $1,600 a year for that policy. The payroll tax would be about 12% of your pay, which is quite a lot when you think about it. And that crosses in other words, the 12% exceeds $1,600 at income of about $78,000. So if you're making less than $78,000, you save money. If you make much more than $78,000 as a single employee with individual coverage, you start to pay more under single payer. I don't know how everybody defines middle class, but I think of $78,000 as being pretty squarely middle class. It's certainly not what I think of as wealthy. Those people aren't buying Birkin bags. It's very different math for family coverage because family coverage in the current system is a lot more expensive than single coverage. But if you have a family with two breadwinners and each is making $110,000, at that point they reach the tipping point, and if they make much more than that, they're going to be disadvantaged by the single payer taxes. Again, I don't think those people are buying, I don't think those are the super wealthy that people have in mind when they think about taxing the rich. The Medicare recipients are another group that I looked at. The tipping point for this is comparing sort of the top of the line Medicare coverage. That's, you know, all of the government provided stuff, and then blanket coverage for drugs and blanket coverage, wraparound coverage with no deductibles. The annual cost for that, when you balance that against the payroll taxes, you're going to cross the line at $62,000 of taxable income. It's a little tricky because there's a lot of retirement income that's exempt from taxes. So all of Social Security is exempt, and the first $20,000 of your pension income, your private pension income, is exempt. New York actually exempts all of public pensions, and so if you have a public pension, you're going to be that benefit of being tax-free is suddenly going to be worth a lot more and the disadvantage of not having that benefit will cost you a lot more. So now let's turn to what this does at the very high end. We're now talking about the farthest right bar on that earliest chart. This is, Mr. Gottfried earlier said, you know, we've raised taxes on the rich before, and people always say that they're going to flee the state, and they never do. I'm going to put to you, this is actually shows the history of the top tax rate in New York State, minus the federal deduction. So the net cost of paying taxes in New York State after you factor in the benefit of the federal deduction has actually been pretty consistent for a long time. And it's been consistently, the blue is New York State and the red is New York City. So New York City adds a little bit, but together they've been hovering around 9 or 10% for quite a while, when net of federal deduction. When they capped SALT, it jumped up to 13%. So that's all that we're living with that now. We now have a higher marginal rate net of, there really is no federal deduction at the high end anymore. But if you add single payer, it really goes through the roof. It goes from about 13 to a little over 30%. And that is, I mean, it's certainly unprecedented on this chart. I think it's probably unprecedented for any state ever in the history of this country to consider a marginal rate that high, so especially just for one program. We would also, this is us compared to other states. Not all 50 states are on there because there's like a half a dozen states who have zero tax, and Texas and Florida being among them. Right now, we're about 10th. I don't know, not everybody can see this, I don't think, but we're about 10th in the states. If you include New York City taxes, we're second behind California. But if you go to single payer, both statewide and in New York City, you're more than double what California is. So you become an outlier in such a dramatic way that I think all of the previous research on tax flight would kind of go out the window, because nothing like this, I don't believe, has ever happened in the United States. So this, I call this Rand's scariest chart because this shows, Rand didn't actually try to predict how many people would leave, but they showed what would happen if people did leave. The bar on the left is the tax base. It's the total non-payroll income in the state, $400 billion. Moving to the right is what happens if 9,000 very wealthy people leave, then 25,000, then 50,000 very wealthy people leave. I don't know, if you can't see it, what happens is that the tax base is cut in half. It goes from 400 billion to 200 billion, just because 1/2 of 1% of tax filers have left the state. Those departures alone would open a $33 billion hole in the budget for the health plan, but that's just the start, because that's the same tax base that the state uses for a lot of the other spending that it does on school aid and everything else. So the author of the Rand report in an op-ed for the Daily News said that there is a risk that the tax base could collapse, and I think that's a fair statement of what this describes. So, as I said before, this is just one scenario. You could imagine if Mr. Gottfried were here, he would say, well, that's not what the taxes are going to look like. We're going to exempt the poor. Of course we're going to exempt the poor. And we're going to protect people on Medicare, and we're going to protect middle-class people. But when you squeeze the balloon, it's going to inflate somewhere else. And so the rates on the upper middle class and on the wealthy are going to be even higher than what we've seen here. So that's what I wanted to talk about today. I guess I would ask the panelists to come up and we can start our second panel. Thank you for listening. This is our second panel. We're going to be discussing alternative strategies for improving the healthcare system, short of single payer. That's not to say that the people up here necessarily oppose single payer, just that I've asked them specifically to talk about alternative strategies. Immediately to my left is Michael Sparrow. He is professor and chair in the Department of Health Policy and Management at the Mailman School of Public Health at Columbia University. He in particular has written about the concept of a Medicaid buy-in, or what he also calls Medicaid for more. Next down the line is Eric Linzer, who is the president of and CEO of the New York Health Plan Association, representing 26 member health plans that cover more than 8 million New Yorkers. And he previously had a very similar job as executive vice president of the Massachusetts Association of Health Plans. And then way down at the end is Michael Capaldo. He is an employee benefit consultant, and he's on the board of the New York State Association of Health Underwriters as its media chairperson. Previously in his career, he was a director of communications and training at the New York Liquidation Bureau, which I believe is now part of the Department of Financial Services. Is that correct? So we had.
It's always associated with it.
I'm going to ask each of the panelists to give a brief presentation on an idea for improving our healthcare system short of single payer, of getting more people covered, or otherwise filling gaps in the healthcare system. And I think we're going to start with Professor Sparrow. Thank you.
Hi, thank you very much, and thanks for the invitation to warm and sunny Albany. Came up and froze, but it's really great to be here, and it was really interesting and fun to listen to the first panel, which had a really thoughtful and informed discussion of the pros and cons of both politics and policy around single payer. And as you just heard, our task is to talk about a couple of potential alternative solutions to try to make the health system in New York a bit better. And what I want to do is take the next 5 minutes or so to suggest that the state consider permitting both the uninsured and the underinsured, some of the folks with high deductibles, for example, that we were talking about earlier, and perhaps more, to be able to buy into either the Medicaid program or one of Medicaid's sister programs here in New York State, the Essential Plan or Child Health Plus. In my view, doing so offers, I think, the best path to affordable universal coverage here in New York State. And it's actually a path that's being considered by a number of other states around the country, such as New Mexico and Nevada and Colorado and Minnesota and Massachusetts and Washington State. And I think New York ought to join that conversation. I feel a little funny talking about politics to a group of Albany politicians and policymakers, but I will start out with just a couple of words about the politics of such an approach and why I think it makes sense, and then talk a little bit about the policy implications and also some of the policy questions that I think we need to explore. But first, politics. When you think about Medicaid, there has been just an extraordinary transformation of that program over the last 30 years as it's evolved and moved from a program that really had its sort of welfare roots to a program that has really been the primary path to insurance coverage for the uninsured in the United States over the last 30 years. And you have to say to yourself, why has Medicaid grown so much? Why do we now have a program that nationally has over 75 million Americans in it, and that has proven to be a pretty popular and resilient and politically adept program across the United States, and certainly here in New York, where you have 28, 24, 25, 26% of the population on that program? And I think there's a few reasons. One, Medicaid's a program that can draw pretty good interest group support from hospitals, from nursing homes, from Medicaid managed care plans and insurance companies, and from advocates on behalf of low-income populations. So I think it gets a good interest group support. I think the Medicaid funding model, the shared funding model with the federal government, is a strong reason why there's a lot of support for it. I think America's political culture, which has a preference for sort of state-based programs to a certain extent, has been something that's really made Medicaid even more resilient over the years. I think We've hit that sort of Malcolm Gladwell tipping point with Medicaid now, where just about everybody knows somebody on Medicaid or somebody on the essential plan here in New York or somebody on Child Health Plus. And I think the stigma attached to the program has lessened. And I also think that, the Medicaid plans and the Medicaid agency here in New York and around the country has done a pretty good job of developing interesting and innovative care management programs for low-income and not so low-income individuals. So I think for all of those reasons, and you saw this last year during the battle over the, the repeal and replace of the ACA, I think Medicaid is an extraordinarily resilient program that I think can provide the basis, for a political compromise and a political coalition that's different from the kind of, politics generated by single payer. I also think Medicaid can provide decent and low-cost coverage both to the 5–6% uninsured here in New York, but also to those who are buying high-deductible plans now on the exchange, or those who feel, as we heard a lot about in the conversation a few minutes ago, that their out-of-pocket costs are too high. You permit people to buy into a program like the Essential Health Plan or to buy into Medicaid, you really have the opportunity to give them, I think, a decent insurance package at an affordable price, and you begin to move, and you're seeing this conversation nationally as well, between sort of the Medicare for all versus Medicare for more versus Medicaid for more. How do we get to affordable universal coverage? And I think Medicaid provides a path, and I think it provides the most plausible path to getting there. Clearly, and I know I want to keep these initial comments short, clearly there are many, many questions to be answered in a conversation about how to make this work. You have to think about who's the target audience, who are you trying to attract, and who should be able to buy into a program like this. Is it just the uninsured? As we heard earlier, half the uninsured in New York State are already eligible for a program like Medicaid or low, or subsidized health insurance. So who is really the target audience? Is it folks who are buying on the exchange right now? Is it folks who are buying and, getting employer-based coverage right now, and would prefer to have the opportunity to buy into a public program? So who's the target audience? What's the right benefit package? What are the right premiums? How do we pay providers? What about those Medicaid rates that physicians, grumble and grumble and grumble about so much? Can you get the waivers? We heard, Representative Gottfried talk earlier this morning about how well the single payer could go ahead even without waivers from the federal government. Well, I got to tell you, it would be really tough to get single payer to go forward without getting waivers from the federal government or getting approval from the federal government to do the kind of things he was talking about. And it would be tough to get sort of a Medicaid buy-in, without waivers of a sort. And so how do you think about those kind of waivers? And is it the Essential Health Plan, or is it Medicaid that you want people to buy into? I mean, those are all really important questions. But bottom line, and I think I'll stop here, bottom line is, in my view, here in New York and in the United States more generally, there's neither the political appetite to sort of eliminate the nation's employer-sponsored insurance system that we've had in this country really since the 1940s, and just to sort of get rid of it overnight or over the course of 2 or 3 or 4 years. Nor, though, is there cross-national evidence that we need to do so in order to have not only universal coverage, but affordable universal coverage. That's, I think, what we're talking about. And we have to then think about how do you reduce the price of health care. But I think what we ought to have a conversation about here in New York is about how to build off of Medicaid to lead, in my view anyway, at long last, to a potentially bipartisan version of affordable coverage for all. So maybe I'll stop there, and we can chat more about it later.
Thank you. Eric?
Great. Thanks, Bill, and thank you for the opportunity to be here today. As Bill mentioned, the HPA represents 26 health plans to provide coverage to 8 million New Yorkers. And when you think about our members, those are folks who provide coverage across the gamut. Individuals who may get their coverage through employers, both large and small, folks who purchase individual coverage either through the exchange or directly through the plans, and then those individuals who are in one of many different subsidized programs. So when you think about our membership, anybody who's enrolled in coverage are probably going to be touched by one of our plans. I think to Michael's point, I'm going to focus a bit of my comments really on the piece about how do we reduce the price of healthcare, because I think there are two challenges that we have. One is, as far as the conversation around single payer, how do we go about closing the gap in coverage from reducing that number of folks from less than 5% to getting to universal coverage? And then second, really addressing underlying healthcare costs. And when you think about who that 5% is, I think this was touched upon a little bit earlier, but it's a combination of folks who are eligible for Medicaid but aren't covered. It's individuals who, between, say, for example, 400 and 600% of the federal poverty level, essentially they make too much for federal subsidies, but not enough to really go it on their own. And then you have low-income, undocumented immigrants. And I think there are obviously different approaches that we have to take, but at the end of the day, I think what you'd hear from folks who've been on today's panel and the earlier panel, and we agree with them, that every New Yorker deserves coverage for high-quality, affordable health care, and that's a commitment that our members share with a whole bunch of stakeholders. The challenge is how do we get there? And I think for purposes of this conversation, I want to focus really on that second group of folks, the individuals between 400 and 600%. And while these folks are the ones that are essentially paying full freight in the individual market, but they need a little bit of help, and we want to stabilize that segment of the marketplace. When you look at other states such as California, Governor Gavin Newsom came out, I think, last week and had proposed making subsidies available for these individuals because you want to keep them in the marketplace. You want to keep them enrolled in insurance coverage, and the challenge really for them is finding a way to get the right subsidy for them, whether it's an after-tax, post-tax credit, or it's some sort of additional subsidy. I think the numbers that we've looked at would roughly cost about $50 to $150 million for New York. And while you may not bring in a whole bunch of new folks, maybe about 20 to 25,000 individuals, it goes a long way to stabilizing that segment of the marketplace. And that's a really important thing, that if we want a functioning commercial market, one, you need to make sure that the folks who are in it today, who recognize the need for it, get a little bit of assistance. But then the other piece to keep in mind here is that, and it hasn't really been touched on much today, except just in the sense of the potential disruption in the market of moving to single payer, is that most folks get their coverage through an employer. When you look at the state of New York, roughly half of individuals in New York get their coverage through an employer. On average, employers pay about 76% of the premium dollars, so there's a lot of folks who are getting their coverage through an employer. And in order to maintain those high numbers of enrollment, and to keep the employers engaged in this market, I think we also ought to be looking at ways to help them. The first step really is to go at looking at underlying healthcare costs. And I mean, when you think about the conversation earlier about the proportion of the premium dollar that goes to pay for medical services, doctor visits, hospital stays, prescription drugs, you're talking about 86 cents of the premium dollar going to pay for those services, and those are things that benefit consumers. But if we're going to get healthcare costs and we're going to make premiums more affordable, we really need to focus in those areas. And first and foremost, I think one area that hasn't gotten a lot of attention, but you look at other states like California and Vermont around prescription drugs, there needs to be greater transparency in that space, both as far as why costs are going up, to be able to engage in a meaningful conversation about how are we going to get at underlying pharmacy costs, but then second, providing the state with some sort of, and purchasers with some sort of early warning system for when price increases are going to exceed a certain level, say 10 or 15%. I mean, these are steps that have been taken in other states. We think it's worthwhile. It gives folks at least some ability to plan for potential cost increases without having a heavy hand of government involved. I think in the provider space, one of the biggest challenges that we continue to hear from our members is certainly around the price piece. And if you look at last year's report from the Healthcare Cost Institute, while demand is certainly a piece that is adding to rising costs, most of the increases that we're seeing are driven in large part by price increases. And a big piece of that has been a result of some of the consolidation taking place in the market. Now, some of it's already happened. There's still additional consolidation taking place, and it's probably worth the state considering ways to think about how we want to deal with, as mergers and acquisitions take place, because the national data indicates to us that, while oftentimes folks will say, we need to come together, we need to generate efficiencies. National data indicates that it's mostly costs go up. So there should be some sort of mechanism to establish either thresholds, benchmarks, guidelines, something along those lines, so that as entities come together, it's not used as a way to generate higher contracting prices at the negotiating table. And then the third piece that got missed today from the earlier panel by some of the advocates is around the role of government. Now, there was sort of talk about 18% of the premium dollar. I don't want to quibble over numbers, but when you take out surplus, and to Sean's point, we're capped at how much profit health plans can make. It's roughly about 12% of the premium dollar that goes to pay for admin, and a lot of that, or a big chunk of that, has to do with government regulation, taxes, assessments, those things that fund a lot of programs. So, dealing with those underlying costs, there is a responsibility on the part of government to be a good partner and not merely point to the fact that, well, premiums are going up, but that government has a role to play but chooses to get ignored. I think the other piece there is that from a benefit design space, there could be things that government could allow for in the market to encourage consumers to use things like transparency tools to provide incentives, to think about going to lower cost providers without, again, having sort of that heavy hand of government, because I know folks are reluctant to get into issues around price regulation, and we certainly don't support something along those lines. But at the same time, if you have a marketplace that isn't functioning properly, you want to get and you want to be able to make healthcare more affordable, close the gap on the uninsured, then we need to start looking at sort of those underlying healthcare cost drivers in order to allow for the marketplace to function more effectively, ultimately for the benefit of employers and consumers.
Thank you, Eric. Michael, your turn.
Thank you, Bill. Morning, everyone. It's a pleasure to be here, and thank you, Bill, for the opportunity to participate. As Bill mentioned, I'm an employee benefit consultant, and I'm on the board of directors of the New York State Association of Health Underwriters, which is the professional trade organization of New York health insurance agents, brokers, general agents, and employee benefit consultants. We're supporters of universal health care. We believe that integrating existing public plans with market-based solutions is the most economically effective way to make affordable health care accessible to every New Yorker. The ideas I'm going to be sharing with you today are not officially endorsed by NYSEU, but they're under discussion. They focus on creating cost transparency and using it to drive down the cost of health care by empowering consumers with that transparency. One of the major failings, in my opinion, of virtually every healthcare financing system is the lack of that transparency and the resulting absence of consumer impact on the cost of health care. Most of us care about the cost of our health care to the extent that it's described on our health plan membership card, if we're lucky enough to have one. Do I pay $20 or do I pay $30? Do I pay $50? Do I have a $6,000 deductible? Do I elect to stay home because of that fact? The New York Health Care Act, as proposed, while eliminating that discussion about cost, would repeat this failure once again by altering how health care is financed without bothering to educate and empower consumers to impact the cost of their health care. Our approach is to take, by and large, what already exists in New York State that isn't being applied to its fullest capacity. How many of you, and take a quick audience survey, are familiar with New York Health Connect? Okay. And those of you who are familiar with it, do you visit it regularly? Okay. For those of us who aren't familiar with it, it's an all-payer claims database. Now, unfortunately, it's somewhat limited in terms of the information it collects. Right now, it's getting Medicare, Medicaid, QHPs, qualified health plans that are sold on the exchange, no commercial information. And it allows for the voluntary submission of data from self-funded health plans, but it cannot force that submission of information. As was mentioned earlier, ERISA-regulated plans, the Employee Income Retirement Act, basically preclude state-based control of those plans. So we'd like to see that expanded, and we'd like to see the information collected on this site to be shared with everyone, both in terms of explanation of benefits as well as an easily accessible website. And the website right now actually is pretty easily accessible. And I commend it all to you to do some exploring. It's pretty easy to use. In this way, we'd be able to see what things cost elsewhere. For example, if you looked up, as I did this morning, the price of a knee or hip replacement in New York City, you'd notice that it's substantially different in other parts of the state. Right now, it doesn't really matter. If you're locked into an in-network provider, you're going to go to the closest provider that's available to you for the procedure. Makes sense, right? What if we added into the mix the ability for consumers to take advantage of differentials in pricing? Perhaps by choosing a provider that wasn't necessarily in network, but met the quality standards of the insurance carrier and was willing to do the job for less money. What would we say if we gave that enrollee the opportunity to share in those savings? A percentage would go to them and a percentage would go back to the carrier. What if we also gave people who really wanted to jump foot first into the shopping game the opportunity to do so? How many of you had health insurance 30 years ago or 40 years ago? I know I'm dating myself. Do you remember something called an indemnity plan? Okay. Why can't we offer indemnity plans again to folks who really want to shop? There are some issues, like the fact that you're basically opening yourself up to surprise billing in a hospital situation. But I think we did something about that, didn't we?
A little bit.
Yeah, I don't know if
We might be able to go further. But
yeah, I think we could. My point is, and I don't want to, I could go on for hours, as Bill knows, he's heard me do it, but to spare you all, we don't know enough about healthcare. I know that sounds crazy in this day and age, but this is such an incredibly opaque, fragmented system. Got a lot of good. It's not worth throwing out yet. But what we really need to do is to work together, every stakeholder, work together to find a way to capture all of the data. So we can sit down and talk about what we know, what we don't know, and then how we go about learning what we need to know to figure out what the right approach to take is. Thank you.
All right, thank you. So we have three very different approaches. We have the concept of allowing more people to buy into Medicaid. We have some ideas for moderating the costs, especially for through expanded tax credits and through better management of provider consolidation and maybe the government thinking twice before it adds new taxes and regulations. And then finally, we have really outside the box, which I mean I think is good in this case, empowering consumers to shop with more information. I guess one approach, one thing I'd like to do is I'd like to get the reactions of the panelists to each other's proposals. So why don't I start with you, Michael? What did you think about what you heard from Eric and the other Michael?
I thought they were both brilliant. No, no. I actually think when you think about, to the extent the conversation gets into prices, and there's no question the reason the reason we spend more on healthcare in the United States is the price of care is higher than anywhere else in the world, and the volume that we use of high-tech services is higher than anywhere else other than Japan. So that's why we spend a lot more. You then say to yourself, how are you going to get at prices? How are you going to get prices? And there are three basic theories as to how you can sort of reduce the price of healthcare. And there's some merit to all three, and I think you've heard a little bit about all three already today. I mean, one theory says, well, the reason prices are so high is because consumers are immunized from the true cost of care. There's no transparency in the system. We ought to give consumers a little more skin in the game with high deductible health plans, but give them much more information so that they can be savvy shoppers. And if they're savvy shoppers, and this is really, I think, Michael's point, if they're savvy shoppers, they'll get that knee surgery, at a lower cost but high quality institution as opposed to the high cost institution, and that'll press down prices. And there's some truth to that, although I think at the end of the day, I have some concerns about that consumer-oriented approach. but I think that's one way forward. Second way forward to think about how do you get at prices is, the second theory is, well, the way you get at prices is not by focusing on the consumer, but the most expensive thing in the healthcare system is actually the doctor's pen. You got to sort of you got to provide the incentive to the provider, to the physician, to the hospital to be more cost conscious, to be more quality conscious, et cetera. And that's what you get with pay for performance, with value-based payment, with sort of trying to encourage and incentivize providers to be more cost conscious. And that's what you really see in the ACA with all of the efforts around value-based payment and pay for performance and bundling and accountable care organizations, et cetera, et cetera. And I think we're the only country in the world that's really trying to get at the high price of healthcare by giving incentives to either consumers or providers. Third theory as to how you get a handle on high prices, which is actually what cross-national experience suggests that most other countries in the world do, is through hook or crook, you regulate or you impose global budgets or capitation. You sort of regulate the price of care. And we don't want to do that in the United States outside of the public programs. We do that in Medicaid, we do that in Medicare, but we don't want to tell New York Presbyterian Hospital how much they can charge Aetna. And politically, that's sort of a no-go anywhere, except for Dick Gottfried and the New York Health Plan, which is going to be telling New York Presbyterian, much to Steve Corwin's disgruntlement, how much it can charge New York State. It seems to me that as I think about the price issue, it's actually very connected with the coverage issue and how you get affordable coverage. That's really the core of what we're supposed to be talking about today. And while I think there's certainly merit and certainly premium assistance, I actually see the premium assistance approach as very similar to what I'm talking about. I see premium assistance as basically telling people in that 400 to 600% poverty level slot that they can in effect have premium assistance to buy into an essential health plan or a Medicaid plan, which essentially is a sort of a private managed care plan, that goes through those programs. So I think as the way I see coverage and cost coming together here is I actually don't think, as I said, we have the political viability or the policy need to try to get rid of private insurance in the United States or here in New York, but that the way you both get greater coverage for folks and also begin to get a handle on prices and costs is by creating more opportunities for people to buy into the public plans, the public approaches, where prices are regulated, while you still have the rest of the state with the opportunity and the option to stay where they are. So I'm getting a little note to stop here, so I will stop there.
Eric, so the idea here is you're going to comment on the two Michaels.
Yeah, so I think Michael has a great idea, and Michael has great ideas.
All right, you're done.
I think when it comes to the notion of buying into Medicaid or the EP, I think that the piece to be mindful of, I think where I might have some pause for concern, might be what's the impact does that have on the rest of the commercial marketplace? I think we want to make sure that we have a strong, vibrant commercial market, and steps to essentially further segment that, I think, could create challenges in the marketplace for two reasons. One, segmenting the market just means we're moving people from one product to another, albeit if you get them enrolled, that's an important step, but it's a question of what the product looks like. I think the second piece is it commercial coverage versus, say, for example, Medicaid or the essential plan? And I think where the concern would come in is, what does that mean for, say, for example, the provider market? If you've got a provider who expects a certain patient mix, patient volume, but suddenly changes from fewer commercial, more state subsidized programs, I think that's a challenge for them. And then the other piece comes into what's the cost shift look like back onto the commercial market. So I think we need to think carefully about that, which is why keeping the focus on that 400 to 600%, providing some sort of tax subsidies, or tax credits to be able to purchase pure commercial coverage, I think is a benefit for the consumer and increases the number of uninsured in the state, and it doesn't adversely affect the provider market. I think on some of the pieces that Michael talked about around transparency, our industry are strong proponents of greater transparency, being able to provide I think the types of products that Michael had said, or the incentives to encourage folks to shop around. One of the challenges is the regulatory environment that makes it really difficult for a plan that wants to offer a product that you see in other states, New Hampshire, Massachusetts, and others, around whether you call it Smart Shopper, Super Saver, where the individual looks to purchase, go to a lower cost provider for certain shoppable services and receive some of the incentive and the benefit back. We've got a regulatory environment that really doesn't allow us to do that. That said, I think transparency is certainly an important piece. Having come from a state where we have a lot of state reports around provider prices, hospital costs, price variation, prescription drug costs, the challenge becomes, once we have the data, what do we do with it? And that becomes the real conversation that has to happen. I think some of what was in the governor's budget, particularly as it related to the commission to look at universal access, that type of information, I think would be helpful in informing the conversation. And it should be a step where we think about how we move forward on some of that. I think the only other piece I would make around the sort of the use of the all-payer database, while certainly being able to get at the self-insured on the challenges that the Gobet decision had created, I would be a little bit reluctant to think about ways to sort of increase additional administrative costs onto the marketplace for something like that. And there may be a better way that we think about how do you get that information in a way that allows policymakers to ensure that there's greater transparency around what the cost of healthcare is.
Michael?
That was a great segue. Thank you. Terrific ideas. I'm looking forward to continuing this conversation in the future. The problem that Eric has with the other Michael's idea is the problem that I have with Eric's idea. And
they're too good.
Which one of us is Tinkers, which one is Evers, and which one is Chance? I might be personally a little bit more comfortable with exploring those. Of course, based on the details, number one. Number two, if we can figure out a way to take what I discussed earlier and apply it on a broader base. Bill said it was thinking way outside the box, and he's right. But here's the thing. If we, let's say, took the all-payer claims database one step further, turned it into a state-funded universal claims submission plan or program, where every provider had to funnel their claims electronically through the all-payer claims database, we would have completely stepped around the problems with Gabile versus Liberty, and we'd have basically almost real-time information on everything that was happening on a health basis in the entire state. The Department of Health would be happy because it would be a tool to identify potential chronic hotspots from a diagnostic standpoint. The carriers should be happy because it would be a repository of de-identified payer information. Blue Cross doesn't know what Aetna pays. Aetna doesn't know what Blue Cross pays. You still wouldn't know who's paying what, but you'd know what was being paid. And you'd have a range and you'd have an average. And if you don't think that these carriers wouldn't use that information to leverage their upcoming contract negotiations with payers, then clearly you're in the wrong room.
Okay, so I'm going to put in a couple questions of my own. Some states around the country, and I know one of them is New Jersey, I think there's a couple others, Massachusetts, strike Massachusetts, I'm not sure about Massachusetts. But they have done, they've stepped in with an individual mandate on the state level now that the federal mandate has gone away. I guess I would ask, going down the panel, I would ask kind of two questions. One is, should the state do that? And second, is it more important as a tool for broadening the risk pool, or is it more important as a tool for raising revenue to do other stuff? Because what an individual mandate ends up really being is a penalty for people who don't have insurance. And so it generates a certain amount of revenue, and that revenue could be spent on backfilling subsidies in other ways. So those are my two questions.
We're going down, I would answer yes. New York State should very much consider doing that. I do not see it primarily as a revenue-raising matter. I see it primarily as a risk pool matter. With New York has some experience from a few years ago with insurance mandates without a mandate, and it didn't go all that well. It led to pretty high costs. And with the federal government, with the penalty for the individual mandate disappearing this year, I think you do see some states considering doing that. And in fact, the New York State Health Department or Financial Services, whatever the regulatory agency is that regulates the actual rates, basically when they came out with the QHP rates, increased this year is of what, 8.6% or so statewide. They were saying, look, it would have been, the requests was 24%, and they're saying a big difference was, the lack of the mandate this year. So I do think it's something New York should consider doing.
Yeah, I think on the individual mandate, Massachusetts does have one. It actually implemented one back in 2006 as part of its health reform package, and part of the argument for it was a way to ensure everybody participates in the risk pool with the expectation that the young invincibles, and everybody always seems to focus on them, as coming into the risk pool as a way to balance it out. I think from where we sit, an individual mandate would be important, but it would need to be coupled with a number of factors that go with it. First and foremost, if you're going to make everybody purchase insurance, then you have to give there has to be a mechanism in place for those folks who, again, don't have access to federal subsidies, but are still expected to purchase coverage. So I think that's where some sort of tax credit or subsidy comes in for that 400 to 600% FPL population. I think the other piece is and it helps to stabilize the marketplace. I think the other piece where it becomes important is if we're going to have an individual mandate, there also have to be measures that be put in place from a regulatory standpoint, particularly around actuarial certification of rates. I know this is sort of a technical, dry topic, but there should be, just as health plans have to stand behind the rates that they submit to the Department of Financial Services, there should be an actuarial certification from those at the department to stand by what they approve. So if there's going to be a conversation about an individual mandate, it needs to be coupled with a number of measures and reforms to ensure that the market, we stabilize the market and it functions properly.
Interesting to note that in remarks after the decision was made on the requested rate increases for 2019, didn't the superintendent comment that their opinion was that the lack of the mandate really wasn't going to impact the rates all that much, if I recall correctly?
I think there was that comment, but there was also a recognition that different plans had different interpretations of the impact the loss of the individual mandate would have on their individual organizations, and a recognition that the Department of Financial Services did acknowledge about, I think it was like a point and a half in premium allocated to the individual mandate. So it did have an effect. It did have an implication. There'd been many months of conversations leading up to the final decision, and like I said, different plans had different interpretations of, after looking at their own individual books of business, what the loss of the individual mandate would have, which is why you had some variation across the marketplace.
Thank you. I think that Eric's points were on the money with this. There needs to be further discourse about certification of the results. I think there's an opportunity there to expand this discussion. Frankly, when you look at some of the results of this latest go-around with price increases, if you dig deeply into them, you'll see a plan that claims a 1 or 1.1% increase, and then you'll notice that the co-pays have been revamped or co-insurance has been added. So in situations like that, when the plan design becomes fungible, I think we need to have a way of assessing on a more accurate, if not broader basis, just what the actual shift in costs is going to be.
I guess I'll just interject something. It just occurred to me, we just got through the enrollment cycle, or well, it's not quite finished, but we're through the bulk of the enrollment cycle for New York State of Health, the Obamacare exchange. And they're reporting higher numbers than last year, and that's with the individual mandate gone. So I mean, does that mean that DFS made the right call about the individual mandate, that like it hasn't been a big, the loss of it is not causing a lot of people to drop their insurance?
I think the initial estimates back in late 2009, 2010, as to the impact of the individual mandate nationally, probably overstated the impact of the mandate. I think, in part because the mandate, the penalty for noncompliance with the mandate was relatively weak. It's also the case that, and this is a little less so here in New York because of the essential plan, but it's also the case that at this point you've got people in the exchanges around the country, and the numbers you're talking about are not just New York numbers, they're national numbers that are not down much, but around the country, 80 to 85% of the people in the exchanges are getting subsidized plans right now. And when they've had those plans now for 3 years, the loss of the mandate is not going to lead them to drop coverage, that kind of subsidized coverage. You're seeing this issue play out in the litigation in Texas right now as to whether or not, what kind of impact the elimination of the mandate has on the ACA. And in fact, some of the same people, ironically, I suppose, in 2009, 2010, at a national level was saying we 100% need the mandate to make the ACA work, are now saying, you know what, the ACA can work and seems to be working okay even without the mandate.
I think, well, we were certainly disappointed with the decision, or the decision around how the individual mandate was going to be taken into account into rates. That being said, I think there's two things to keep in mind. One is the Cuomo administration, unlike at the federal level, has invested heavily in making sure folks were aware of what open enrollment looks like. We've extended open enrollment well beyond at the federal level, whereas at the federal level, there's all sorts of barriers to keep people from trying to get coverage. I think New York's done a really good job in outreach and education and advertising about that. I think the second piece, though, to keep in mind here is that I think it was around April, May, June of last year, the Kaiser Family Foundation had a survey that asked folks in the non-group market if they were planning on purchasing insurance in the upcoming year, and roughly 90% of respondents said, yes, I'm going to purchase coverage even with the loss of the individual mandate, and that was consistent with the previous year where you had 90% of respondents saying, but those are folks who had coverage. So as you get sort of 10% and 10% and 10%, suddenly that universe starts to look a bit smaller, and I think it recognizes the fact that there are going to be folks who see the value, recognize it's important, and need to have coverage. And then there's others who I think we get nervous that are going to decide to go without until something catastrophic happens, and that doesn't bode well for this, maintaining a stable marketplace.
Interesting point. New Jersey instituted a mandate. And I believe their open enrollment results were actually substantially down, somewhere around 13 to 15% of what they had the year before. I honestly don't recall if it was new or renewal, or maybe it was across the board. But there have also been some shifts in subsidies. I was actually exploring this a little bit on healthcare.gov, and if you compared a subsidized versus an unsubsidized situation, it seemed that the unsubsidized person's premiums went down slightly, whereas the subsidized person's went up. Now, I don't recall what type of silver loading strategy New Jersey used, and there's somebody smiling. We've all been spending too much time on Twitter, haven't we? Anyway, the point of this is that any discussion you have about a mandate is going to end up including what the penalty is going to be, and as Bill framed in his question, what the point of it is. One of the issues with the mandate for most people, I think it wasn't a sufficient incentive for people to buy insurance. It's a heck of a lot cheaper not to buy insurance from the standpoint of disposable income if you weren't sick. And then you get into the social impact question in terms of, well, are we doing ourselves a favor as a society, at least those of us who pay taxes, by saying, hey, you know what, it's okay, go to the hospital when your health care blows up.
For this question, just to warn you, Michael Capaldo, we're going to start at your end of the panel for a change. Mayor de Blasio recently announced this kind of new and creative approach to universal coverage, and that was to just take the services that the city already offers and repackage them and call them universal coverage. I'm being a little bit flip, but as I understand it, he's saying that everybody in New York City who doesn't have insurance has the option of either signing up for insurance or using the city hospital system on a sliding scale. Which, I mean, they've had that option all along, more or less. The rest of the state doesn't have a public hospital system the way New York City does, but it does have, I mean, all of our hospitals are not-for-profit. All of them have an obligation to do charity care. All of them all of them are operating under a law which requires them to provide emergency treatment regardless of ability to pay. And I'm wondering if that is an avenue to move towards universal access as opposed to coverage, but what the pitfalls of that would be.
Okay. Well, any PR professionals in the room? Okay, if there were, I was going to ask for an opinion on whether or not Mayor de Blasio's plan to turn old wine or put old wine in new casks was successful. I thought it was a brilliant idea from a PR perspective. Notice I said from a PR perspective. I think if you took the uninsured population and divided it into the amount of money that he's allocating to cover this, it comes to about $129 an individual. So clearly it's not going to be health insurance. But what it is, as I understand it, is a form of triage, sort of forward-thinking triage, if you will. My understanding is that each individual who wishes to be involved in the program will be assigned a primary care physician, and that physician is going to be their guide through the healthcare process. So instead of going to the ER at an extraordinarily inflated cost for something that may not require ER services, they're going to have a primary care provider that's going to guide them. One of the things I think you need to accept as you drill down towards universal coverage is that we don't yet have a working definition of universal coverage. We want to look at it as everybody. There are some countries in the world who say that universal coverage is, and before I go there, I don't recall who they are. I was looking at a World Health Organization study, but they accept the definition of somewhere around 94% of people in the country covered as being equating to universal coverage. There are going to be some folks that you're just not going to be able to get to sign up.
So, Bill, I think what the mayor outlined, is an interesting approach, building off of the current infrastructure. And I think from where we sit, that this demonstrates that there are ways to get at the uninsured. There are ways to address the number that sort of close the gap around that less than 5% in the state. But if but at the same time, there probably needs to be a recognition that what may work downstate may not necessarily work in the capital region or out in Buffalo, but there should be an ability to think creatively about that. In the previous panel, Chairman Gottfried had said, if somebody has a better idea, but he hasn't heard one yet. But what New York has done is, looked at how do we ensure access to care for roughly 600,000 individuals, which if you were able to, depending upon how you count it, that would cut the number of uninsured in half from 4.7% to roughly 2%. So it's an interesting idea. It's an interesting concept. Building off the existing infrastructure is something that I think that's where the focus needs to be, rather than sort of blowing up the entire system, trying to start with something that's new and improved. Why not focus on the things that work, that people what people understand, and recognize that we shouldn't be disrupting coverage for millions of New Yorkers at the expense of trying to institute and create something that, for all intents and purposes, hasn't worked and is largely untested.
I think the mayor's idea is an interesting one and a good one. I think it's, of course, also true, as Michael said, he gave his speech on the same day that President Trump was giving his national talk on the wall. I think he wanted to make a statement about his support for coverage for undocumented folks in New York. I think he wanted to express the principle of universal coverage, and I think he wanted to help HHC out a little bit. My own reaction to it is, number one, it'd be a good idea if actually New York City could expand the delivery system to include the community health centers and other public health clinics in New York. And number two, I think that's a way you can develop the same kind of network statewide. I mean, there was a comment earlier about access to care in medically underserved communities around New York State, and there are many medically underserved communities in New York State. And I think in those areas, that's where you have to think about, you know, reaching populations with community health centers, with nurse practitioners, through retail health clinics of one sort or another, et cetera, et cetera, et cetera. And I think, you know, building up the delivery system, the safety net delivery system, and providing some subsidies for that safety net delivery system to care for people, I think is an excellent idea.
So we've come pretty much to the end of our scheduled time, but if it's okay with the panelists, we can take some questions from the audience. If there are any questions from the audience? Or have we totally exhausted the topic? Yes, in the back, Brian. Oh, excellent.
Thanks. I think actually Michael Spare is the only one I don't know. Nice to meet you.
How you doing?
So there's a proposal floating around that would expand the access to the essential plan for people up to 250% federal poverty level. I think the idea here would be close off that silver loading population, but not cause a crowd out effect with people who might otherwise buy a QHP, like a bronze. So you cover some of these people who are most vulnerable if they choose to get into it, but, and of course you have to do this with state dollars, but you don't cause a runaway effect where, you know, all kinds of people who are currently buying commercial coverage, you know, at all levels start running off to, you know, a buy-in program. I was wondering especially what Professor Spare has to say about that, but to the whole panel.
Sure, I have to confess I'm not familiar with the proposal on the books right now. So it's a proposal that would take it to 400, oh, just up to 250. I mean, I actually think that's a good idea. I actually would go higher myself. I think in New York you have, what, about 900,000 in the essential health plan and about 300,000 or so in QHPs. Those numbers may be off a little bit. But I guess my question, listen, I think when you're thinking about the details of a buy-in, even if you went above, I would allow people above 400% to buy in to the essential health plan, although there's a lot of details that would need to be worked out. I do think you have to think about issues of adverse selection and who's buying in and what it's going to do to the other markets. But I think it's definitely an idea worth exploring, and I'm pleased to know that there's a proposal on the table to do that.
Yeah, Brian, it's an interesting idea, but I think at a time when you've got limited state resources, I think the question comes down to, you know, where are you going to be able to shift those dollars to expand coverage and get more people enrolled. You know, that might be the way to go about it. I still go back to the sense from an equity standpoint that if you're somebody who, you know, gets to 401% FPL, you basically fall off the cliff and you're paying full freight. To be able to provide some relief to those folks, you know, again, you may not bring in, you know, huge numbers of individuals the way you would for certain other populations, but depending upon what the pool of money is and what the goal is, you know, I think it depends on sort of where you place the money. Going up to 250%, you know, certainly would provide some additional relief for some individuals, but at the same time, you know, those folks who are going at, you know, on their own, you know, I think it raises questions of, you know, shouldn't we be providing at least a little bit of support to those individuals?
Or both. I mean, just, you know, I don't think it's an either-or situation. I think there's no question people in that 400 to 600% range need some help. I'm not sure if a tax credit makes more sense than letting them buy into a program, but I think.
Okay.
Yeah, I would have guessed, yeah.
Before the first panel came up, I had the opportunity to have coffee with a couple of people, and they come from a different aspect or part of the healthcare industry than I. And chatting with them, I was reminded that nothing happens in a vacuum, and we all have to kind of step away from letting our own views and interests rule our thinking. And I think that to comment on a proposal like this without acknowledging the idea that there are so many other moving parts that need to be folded into the conversation is dangerous. I mean, just purely increasing subsidies, I think, at any level is kicking the can down the road. If we are not tackling the truly hard question of how do we drive down the cost of health care to the point where perhaps as it's currently financed, it's affordable, we're missing the point.
Any, yes, sir.
Thanks, Bill. This is really for the professor. I'm Ken Bottom, a partner at Squire Patton Boggs and the director of the Empire Center. I know nothing about healthcare, and I haven't been to a doctor in a long time, so that's one point. But here's the point. One of the things I do is do residential real estate for not poor people, but the working poor, the 20 to 40,000 guys who work in warehouses, healthcare, that sort of thing. One of the things I've observed over the years, and I'm sure, Professor, you know what I'm talking about because this is a public health issue, and I think it impacts on what you're talking about here, is some very large percentage of not so well educated, as the president would say, persons don't know how to eat properly. They don't know how to take care of themselves. They don't have the proper education. They never got it when they were in public school. And this is now at least into the third generation of people who eat badly, don't exercise, and you see diabetes, heart condition. I can go on and on and on. There's no wellness standard in this country, and there's no education or motivation for wellness. And I can tell you that when I go around and check the waste bins, they're always loaded with pizza boxes and wrappers from Big Macs and so on and so forth. And when I check an apartment where a new tenant's moving in, the microwave and the oven have rarely ever been used. So I think there's another problem that you could cut the cost of healthcare substantially if people would take better care of themselves and eat properly and get proper exercise, because we try to provide good housing for them.
Sure, I agree. I mean, and there's no question, and listen, I'm from a school of public health. I think there's a tremendous amount of evidence that nobody would dispute that the so-called social determinants of health are critically important, that where we live and our income level and whether we take care of ourselves are critically important. And part of the challenge is how do you build, and that of course gets into questions of income inequality as well, and so, Say that again, I couldn't. Well, I think education and knowledge is part of it, but also you've got a lot of moms who are single moms with kids and they don't have much money, and so the dollar value meal at McDonald's seems like the way to go. I mean, I think it's a combination of things. I think your general point, excuse me? I think your general point is a good one, that we ought to be thinking much more about public health, about prevention, and about how to try to encourage people to live healthier lifestyles. I think there's no question about that.
Any more in the back?
Hi, I'm Peter Warren. I'm the chair of the local Democratic Socialist chapter here in Albany. Oh boy. So Spain's economy is roughly the same size as New York, about $1.4, $1.5 trillion. They made a long transition from their pre-existing health condition system, 1963 to 1986. By 1986, they had full single-payer coverage. So how could they do this and not collapse their economy in the way that Bill was talking about? Some sort of a magic trick? This is an apples and oranges comparison, since Spain I've been to Spain and traveled around it, is a pretty industrialized, modern state, you know, EU member and so on. So how did they accomplish this? And cover maybe
Sure,
only 94% of their citizens,
sure.
but did this on an economic base about the same size as ours?
Yeah.
Just wondering.
Sure. Listen, there's no question. I mean, we could spend 3 hours this morning on cross-national experiences around the world in which you have some countries like England and Canada and others, England, which has a national health service, and Canada, which has a single-payer system, and France and Germany, which have hundreds of private insurers that are regulated, nonprofit private insurers. You know, each country, I think, has a different history, a different culture. Taiwan basically decided a number of years ago that they wanted to figure out the best healthcare system in the world and adopt it for their people. They went on a worldwide tour, and they ended up picking a single-payer system, and they implemented it and seemed to do pretty well, and it's doing pretty well. I think, you know, the question isn't so much how do other countries accomplish what they've accomplished, to me anyway. The question is, you know, what is the history and the culture and the economics and the politics and the market of any particular country say about where they are and where they should go? And I think, you know, it's extraordinarily difficult, I think, for me to think about the United States simply saying, well, we have a $3.6 trillion healthcare system right now, you know, just sort of completely upending that system in a way that I think is politically not viable, quite honestly. So part of the reason I'm interested in the idea of public plan buy-ins is because it seems to me anyway, and I could be wrong, I mean, I think we're all up on this table, all of us who've been up here this morning are struggling with these questions and these issues the same way you are. I mean, this is not easy stuff. You know, and I think for me the question is, if we look at the last 30 or 40 years here in the United States, how have we moved from a country that, you know, 20 years ago had, you know, almost a fifth of its population uninsured to a country that now has less than, you know, double digits uninsured, and a state like New York has 5% uninsured. And I think we've done it through incremental steps. And I think that fits our culture. And I think Medicaid, in my view anyway, provides a vehicle for a path toward universal affordable coverage here that could work. Would that model work in Spain? Probably not. Would the Spain model work? It's kind of like, you know, there are folks who say, geez, if only we could transplant the Mayo Clinic to New York Presbyterian, you know, to everywhere in this country, we'd have a much better health system. That's true. But you know what? We can't just pick up the Mayo Clinic and drop it everywhere. So to me, Medicaid provides a conversation starter in ways that some other proposals don't. But I think your point is a fair one. I take your point, you know, at face value. And I think these are the kind of conversations we should be having.
So on that note, I'm going to thank our panelists for an excellent discussion. And thank all of you for coming. We got off to a rough start, but I think it worked out really well. And thank you all for coming.